Good day, everybody. My name is Skender Daerti, and I'm proud to be your host today for the Value Analysis Expert Series. I'm joined by the esteemed panel of Barbara Strain, Jenell Robinson, and Terri Nelson. And we're going to be doing something a little bit differently on the Value Analysis Expert Series. We're going to be kicking off a mini series within our series called the Creating Value Series. And today will be the tip off of that opportunity. Across the Creating Value series, we'll be talking about a number of different topics, primarily centered around value analysis processes, conversion compliance, understanding how value analysis is managed across different types and sizes of providers, and how product recalls or quality issues impact value. For today in particular, because we are launching the new year and we're launching the Creating Value series, being that it's at the very beginning of the year, and we're coming off another kind of quasi-turbulent, tumultuous year in 2025. 2026 is probably going to feel like a spa day comparatively, but we'll find out how that works. But we're already starting off 2026 with new CMS changes. And those CMS changes have trickle-down effects on everything from value analysis and the processes and everything that goes through it. So in the thought behind the Creating Value series is, how do all the parties, and there's really three core parties to a value analysis process. There's the providers, the healthcare providers, the giver, the physicians, nurses, techs, et cetera. There's the value analysis team. And then, of course, there's the supplier. How do those three parties really come together to ensure that the optimal amount of value is being created? Well, the first question is, how do you define value? People have been using one calculus for a long time. What is that, Barbara?
Thank you, because people would say, now, if Barbara Strain doesn't say this, it's just not an event, right? So if you've not heard me say it once, you've heard me say it probably over 1,000 times. My co-host and everybody else are going, oh, yes, Barbara, tell us what it is again. Value is equal to quality divided by costs. And they're saying, well, is that just something that somebody just throws out there because it looks nice, it's cute, or whatever? We actually use that every single day when we're performing value analysis, when we're working with suppliers, when we're working with others. We're using that. And whether we actually write it down and say this is this and that, we're looking at those components. So you have to think about this, and you can use any example you want, whether it's a household example. Somebody said today about what that kind of meat they were buying and where they were buying it from, or their gasoline or whatever. It's all value analysis. So the value is equal to that quality, but it's how you define quality. All of that particular equation is used in almost every industry that produces something, or you want to get to a decision and you want it to be very data-driven, all of those certain things. In healthcare, quality can revolve around a product, or it can revolve around a whole service we're doing. It can revolve around workflow. It can revolve around quality outcomes, patient outcomes, safety outcomes, risk, whatever it is. Quality is really key, because right now, could you say to yourself, whether you're a manufacturer or you're a provider, in each of those sectors, could you say 100% everything I do is at maximum possible best outcome? If the answer to one or more of those as you're thinking about it is not really, that's where you have to look at, what is it? What am I not meeting? What is that quality? And all through there is, I'm spending more money, or I'm not getting to right patient care, or I'm not getting to the right thing over a period of time that's costing me more money. How do you actually look at that? And then if I'm going to make a change in this or that, what do I need to do that with? And then how much will that cost compare? So you wind up with two different numbers a numerator and a denominator. And when you divide it, you hope it's of greater value, over zero, that you're creating this. And then you watch the dollars fall out of things by doing the right thing at the right time for the right reason.
So, Terri, let me come to you to build off of that for a second, because quality is a very esoteric term, and being esoteric, there's subjectivity to it, right? There are probably some providers that think by symptom mitigation they've created quality. There's probably some others that say by getting them back home I've created quality in a shorter time period, right? And I know you're probably going to say it's an amalgamation of multiple things, but how do you take something that's esoteric and subjective and turn it into something that can be objective in terms of a quality metric?
Yeah, good question. And I think it can be objective as long as you look at all the components to it. And Barbara just identified what those were. Quality can be defined. I'll use an example. I feel like I need to use an example because Barbara used an example and makes me feel bright. That I'm giving you quality if the patient likes it. To your point, that's very subjective. How do you know the patient likes it?
Right.
What did they tell you they liked it? Did you do a survey? And it might be that the differentiation for quality, whatever you're measuring, is patient satisfaction. So now how do you measure the patient satisfaction objectively? Are you going to do a survey? What does the survey look like? Those kind of things. And so looking at the value equation and just thinking about value equaling this quality over cost is really limiting. And that's why I'm so glad we started that off and we're looking at this series, because it's all of the components working together. It is the patient population, the quality. I want them to have certain blood levels at certain intervals when we do medications, right? I want this to be at this level. That's where you have to look at, am I going to be able to even capture the testing results? How do I do that? So it's looking at all of the different components along the line and making it objective. And this is the part I talk about with value analysis, that's the hardest part of our job. When we do validations of products, or when we look at this in particular, staff will say, well, I can tell I don't like it. What is it you don't like? And we keep drilling down into that. And the value is for it organizationally. What Barbara said is now we really can see the value over the cost. We can understand when we drill down, and it's the fact that it has to be pink because it's the only color that stands out when we do this procedure. That was all right. That tells us that, and it has to be a certain level, and that's where we're going to generate that cost then. So pink costs more. Well, maybe more because the outcomes is the patient's procedure is going to be more successful because it was pink. And that's what we have to do on a regular basis. And if suppliers look at it, also this way, since all three of us work with a lot of different suppliers, it's not just giving me the cheapest product, but it's meeting the other quality measures over it. And so we have to continually look at, if we're driving value, do we meet all the measures in this equation?
So Jenell, coming to you, we're calling this creating value, right? And that's a phrase that both of your peers have just used a couple times. But it seems like in the creating value is a byproduct of discovery, really, right? So help me understand, how do you create value when you're still doing discovery in a process that you're supposed to be creating value?
Right. Great question. And, I just want to back up just a little bit. I think value comes in many forms. When people talk about value, they think about a number, right? Most commonly dollars. But value comes in many forms. Value comes in many different shapes and sizes. And I think in order to really assess value, it has to do with how much. What's meaningful? Meaningful value versus just a number. Is 2 greater than 1? Is that meaningful enough? And that's kind of what value analysis does when they're evaluating something that is still in that process. Is, you can call it what you want. You can call it retrospective review. You can call it a case review. You can call it a look back, whatever you want to do. But the bottom line is, regardless, I think, of if you're looking at a process measure, an outcome measure, or some of those like priority measures like patient experience or care coordination, efficiency, whatever, the CMS buzzwords are that you're assigning value to, it really has to do with taking what was our baseline before the implemented change, whether it be a product, process, whatever it may be, and then evaluating it after. Is it more efficient? If it's more efficient, how much more efficient is it? And is it a meaningful value denominator or numerator? Numerator, I guess it would be, right? Quality equals value over cost, numerator. Is it meaningful enough? So when you start talking about, let's take efficiency, for example. Efficiency is a big one. Efficiency has a snowball effect. So cutting time in the OR not only improves potential, depending on the procedure, but patient exposure to anesthesia, radiation, whatever it may be, staff exposure to radiation if it's in a, radiative suite, shorter recovery time, shorter PACU time, possibly inpatient or outpatient, from an inpatient procedure to an outpatient procedure. When do they go home? What does it look like? So there's all of these tiny little factors that go into trying to discern meaningful value. So, example that I always use is it a process or a device or whatever it is that shaves 5 minutes off of a 30-minute procedure? That could have some value depending on the end of the day, and then the operations come into the equation on what does that look like for hospital operations. We know it may have a patient benefit, but what are the other factors? Who are the other folks that are influenced by this particular change, right? Now, 5 minutes on a 4-hour procedure, while it still has some of that maybe patient value, where is it in the efficiency process? Where is it in the outcome process? And is from a hospital operations perspective, is it really meaningful at the end of the day? It falls way further down on the relative value or overall value of that product or item or efficiency or, what I'm trying to say, process, whatever it is. So value is really a blanket term, but really has to be dissected down. And that's what value analysis does. It gets into the weeds, gets into the nitty gritty, looks at patient populations and finding the variables and say, okay, well, in this population, perhaps the outcomes or the efficiencies or whatever performed as this, is that meaningful enough as compared to this population? And there may be differences, and that's okay, but it may not always be. I know I'm kind of word salad here, diarrhea at the mouth, but I guess what I'm trying to say is that it doesn't always necessarily have to be a singular numerical calculation that results in quality.
What you said, Jenell, I think of all the words you said, which were excellent. One of the things that stuck in my mind was the baseline has to be agreed on.
Yeah.
So whatever that is, it has to be agreed upon. And so the supplier and the practice, the provider, need to have agreed upon that. And I always think the voice of reason is value analysis.
Yeah.
We're not the approvers, we're the facilitators. But that baseline, agreed upon baseline, just start, and your baseline in our organizations, we've talked about this before, the center of everything we do is that patient. So the baseline has got to support the patient. I mean, it has to have influencing better outcomes or processes for that patient. They always have to be at the center.
That's a good point, Terri. When you talk about baselines, a lot of the baselines that are brought forth or that are compared against are the proposals that are provided by the supplier. So I think this is where the supplier comes in and really is very open and honest about the outcomes that their solution provides. Because most of the time, especially in different organizations, and depending on maturity and whatever, that may be the only baseline. That may be the only factor in the baseline that's compared against, is what those proposed or purported changes are. But you may actually end up peeling back the onion and finding a completely different value than what was proposed. Mm-hmm. And so it creates value in that way. And I think that's where suppliers, where it's really in their benefit to work with that value analysis coordinator or team that says, hey, but have you thought about this? Or this is where we uncovered value in that. How come that isn't in your marketing material or your sales or whatever it is? So it's kind of a scratch my back, I'll scratch yours type of, I know, Terri, partnership is a loose word with you, but relationship.
Relationship. Converted yet,
relationship. Where you can really help each other, and then that comes along with the, the agreed upon baseline.
So a couple of the points from listening to all of us, but especially to the last couple of minutes, is now you see why we have to bring so many different people to the table to have these discussions, because it's not just a one-on-one type thing. Well, this particular, say, procedure in cardiology, this will affect that. But then it's like a spider web that goes out. So you have to understand why our teams are very diverse, and we then bring in other stakeholders as we discover all of the nuggets and things. Mm-hmm. And then you need to understand how we can make those decisions with all of the information that everyone is providing, including the supplier. But one of the most amazing things, I kind of sit back and smile when I'm on some calls with some teams or whatever these days, and they discover something about their own internal practice that this group didn't know, but this group did know, and how you can see the light bulbs go off. And then there's much more continuity of what that care really looks like when you have all these constituents together. And it just started with one little idea that might not seem very meaningful, but turned into a whole project that also went to affecting reimbursement, a variety of things. And they got very excited at all of this.
So let me ask you, ladies, and Terri, we'll start with you. How is value creation going to be different in 2026, or is it going to be? And when I say for 2026, remember, we're talking about kind of three parties that we want to have them come together in this. So how's it going to be different for each of the parties?
Such an interesting question. I think the difference is going to be including, and I know we're going to get to some of the regulatory requirements that will be changing, not just in 2026, but going forward. There, it's an evolution, right? That happens. I think there continues to be a lot of pressure on the cost. So I repeated multiple times, value analysis are not the decision makers; they're the facilitators of the process, and sometimes that's not going to change, is that we continue need to be that facilitator, be realistic about cost. But if the cheapest product doesn't achieve any of the outcomes that the organization has identified, then that might not be the right product to go through, even though financially it looks like the cheaper. But I think there's going to be a lot of pressure internally on the provider side to continue to decrease cost. And that's where value analysis becomes even more relevant. But my concern, just as we've been talking, is organizations looking at costs. And we all know, I'm hoping we've gotten better at this, but a lot of times the first thing to decrease is FTEs, right? I look at my FTEs and where they're planted. And if I don't have a individual that's doing lots of different things and able to articulate it, that's on value analysis. They need to articulate what they do and the value they bring to the organization. But I think that could be influenced tremendously. I'm actually hoping in the positive that the more we share these types of podcasts with suppliers and they understand the relationship that you have with a provider supplier and the value they can bring to this, I think it's going to be a better relationship overall. I've said relationship 3 times. Sorry about that. But it's going to, what we'll be able to do is achieve better outcomes for the patient. I know you all, I just have to keep thinking that because that keeps me rooted. I know that the organization I worked for many years, that is what we said every day, but you all did too. It's not just one organization, everybody. And right now, more than ever, we need to think about how we are impacting that patient in a value way with changes in insurance and reimbursement issues that are going to happen.
So Barbara, same question to you. How's value creation changing in 26 for the various parties?
So one is a lot of people really don't talk that language. So we want to instill creating value. And I say it whenever I have an opportunity, whether I'm doing a class for ARM or doing a panel for someone else or whatever. It's we really help to create value altogether. So right now, things are really looking at shifting more care to the outpatient side and looking at chronic disease states and how do we help to control that outside of a hospital? How can we control more things outside of the hospital setting? Because it's more expensive. You expend too many days there as well as the care. So nurses in New York went on strike yesterday. That's a lot of nurses.
16,000.
Yeah. And so what's happening today? You got an administrator coming down and saying, "What do you need me to get a glass of water?" I mean, it's a big deal, right? So there's going to be a lot of those I was going to say surprising sort of things that might happen. I didn't know that a strike was brewing until yesterday, and then they said, "Oop, it happened now at this time," right? So what do people do and how do they plan? But I think there's going to be more of in everyone's lane. They have to think, how can I bring value? But we're not just limiting it to the patient. It's all those things leading up to the patient that helps the patient be successful in their stay in a hospital. So it's those taking care of them. It's the ancillary that either touches or not touches, but respiratory labs, OT, PT, name all those things. It's got to be everybody working in all those concentric circles towards the patient.
And so, Jenell, what's your take? How are things going to be different in 26?
Yeah, I think my whole idea on this, and I may be wrong, but it's really going to take a change of thought process. No more, I don't believe, fitting into the same, template box of this is how we create value. This is how we demonstrate our value. That's the old way of thinking, dollar for dollar. Things have changed. Now we have to start thinking in terms of higher scrutiny and more comprehensive look back, reviews, analysis, whatever you want to call them, to actually demonstrate, the value. The value may not always be apparent at the pump, at the time of adoption, at the time of inception, at the time of process change, whatever it is. And I think value analysis is starting to, move along with this, where that low-hanging dollar for dollar, your obvious cost, the supply type cost, where that equation has changed. But I think more theoretical decisions will be made. When you start talking about outcomes, hospitals may be forced to make more theoretical decisions where, okay, this looks like this could happen. Here's the proposed outcomes, whether it be less hospital days or, getting patient home earlier, quality of life for the patient, or, patient satisfaction surveys, whatever those are, those proposed outcomes or those more, what's the word I'm trying to think of? I don't know. don't know what word I'm trying to think of. But those more subjective, I guess, outcome measures that still propose value in the movement for value-based care and creation are seen later. So I think that's how I see it changing, is I think more theoretical decisions will be made under higher scrutiny, followed by a comprehensive look back.
Yeah.
Review.
I think both of you said that too, that it's not, we're used to reviewing contract, getting it implemented, looking at compliance, and then it goes away. But it's not, and that may be 6 months to 12 months. It's going to be longer in some of these cases. And the other part that Barbara brought up was the setting. Patients are shifting, the hospital at home concept. And for value analysis, we need to know what the organizations that we're working with, their groups that we're working with, we need to understand where they are with that. Because we still need to look at products and services that are going to be provided in a different environment. And if you separate them out, you're going to lose that. Oh boy, how many times have we said value? I hope that we have a monitor on this and can say how many times, because the whole idea of it being a hospital at home concept is that it brings value, and it's some subjective value to the patients, but same clinical outcomes. But we need to understand how they're setting those up with the right products so that we can make sure the organization's getting financial value as well.
So quick round robin between the three of you. We talked about CMS changes, et cetera. Of the three parties that we've referenced, who do you typically see, in your own opinion, as being the most aware, knowledgeable, and reactive to things like CMS changes the fastest?
Providers.
Mm-hmm.
Yeah, because they're the most effective.
Yes, their effectiveness.
Which is funny, because from my perspective, I always feel like the end user clinicians are the last to move. Now, again, if they're in the clinic setting where they have a greater stake in the game, it's a different story, right? They are acutely aware of how those changes impact them. In an acute setting, in an acute hospital setting, I typically have found, and this may just be my experience, they're the slowest to be aware, because the trickle-down effect, from what I understand, doesn't impact them until somebody hits them with their new RVU structure.
That's where Barbara brought up, it takes many people. And so when I'm thinking you are absolutely correct. But when I was thinking in the provider space, I'm thinking of all that, the administrative support, the reimbursement, the finance department, everybody. And you're right. The thing for clinical staff are busy taking care of patients. So you have to have a balance there. Who's the right person that needs to be part of that team, because they need to have a voice. But so when I said providers, I was actually...
You meant providers holistically.
That whole thing, yeah.
Yep.
Because we would do little mini sessions, Emma and I, at our teams, talking about here's what's new in reimbursement that we will bring up during the course of discussions that may affect you. Some departments in the hospital are more attuned to those things because it will directly affect, am I going to see 1,000 patients this year, or am I going to see 850? Because now with these new reimbursable codes from CMS trying to drive things to stay more at home and do things as either outpatient clinics or whatever it is, I don't need as much in the hospital. But what's that doing to my, the physician provider versus the overall organization, monetary revenue stream and everything? And what I keep trying to tell folks is that you have to understand you don't have to budget and think of your finances just like it was last year, because you have to understand what's coming at you and to understand you may not have more or less patients in this setting versus this other medical setting or whatever. Could be ED versus inpatient. It could be clinics versus outpatient surgery centers. It's all different. And you gotta, I think I said this last week on something else, but You've got to keep your stuff going the way you know, but plan for all these. And then in some cases, you actually have to strategically push them in that direction from your leadership in your hospital, making sure everybody's on board so no one's left surprised.
So this is the kickoff of our Creating Value series. I think we've laid a very good foundation for subsequent discussions, again, relating to conversion compliance, understanding the differences amongst the different types of providers and how their value analysis may be different. And as you stated, product recalls, et cetera, et cetera. Along those lines, ladies, in a wrap-up effort here, what are some of the things that you hope you want to leave people with to take away from this series, not just from today? Terri.
Oh, yeah. Okay. I think how we all work together. How do we all work together for the good of the patient? I think that's the key thing. And you can't just do it in one podcast, even though, brilliant minds are talking right now. You've got to have a foundation that you can build on so you can take off chunks.
Beautiful. Barbara.
I think, like you said, we've laid the foundation. Hopefully we've set enough out there that people will come back week after week, because we're going to help hold their hand through these things. And it'd be great if somehow we could get some feedback about what are some concerns and things. And maybe it's something we can work in at some point. But it's really, how do we get people over this on both sides so then they can continue to work together towards good value, but in a lot of different ways in which they have to think about things.
Mm-hmm.
Jenell.
I would like to leave people with an understanding of all of the little different weeds that encompasses value analysis, not just that high level 50,000 foot level that we talked about in our first series. If I can't leave them with an understanding, because it's complex, it's very convoluted and very complex, and every, I think, initiative is looked at a little bit differently, but I would at least like to leave with an enlightenment, and that it's more than just a one-off. And then that will hopefully lead, I think Terri said, to being able to work together and to discern that value, because value is not going to be that low-hanging fruit anymore. You're going to have to dig deep into the woods on some, circumstances and really drive out that value.
Love it. Ladies, thank you very much. Great foundational work. For anybody that is listening right now, we do encourage you to tune in to subsequent ones, because all the bits of wisdom that the ladies have just talked about, that's what we're hoping to impart upon the next and subsequent recordings that we have here. Please like us, please share us, please watch, listen, however you take your podcast in, please do so. We are very excited to impart some good information as it relates to how every piece of that triumvirate involved in the value analysis process can provide greater effectiveness at creating value across the series. So thank you, everybody. Appreciate it. Look forward to listening to you ladies talk again in the next episode, which we'll be talking about conversion compliance. Thank you, everybody.
Thank you.
Bye.
See you next time.